This is a sample diagnostic approach to headaches in the emergency department. While this lecture excludes pediatric patients, there is a good review of pediatric headaches by EB Medicine from July of 2013 that you can reference for pediatric specifics. One of the most important features of headaches to explain is related to their pain pathway. Since brain tissue does not have sensory neurons, you cannot feel your own brain tissue. Therefore, headaches come from the dura tissue, such as from stretching or inflammation or vasospasms. Therefore, a patient's pain response to medication cannot be used as the sole diagnostic indicator of the underlying etiology. The main purpose of a medical screening exam is identifying time-sensitive diagnoses. Of course, if there is any compromise to a patient's ABCs or any instability, toxic appearance, or concern for need of acute interventions, notify your attending right away. Headaches in pregnancy, especially after 20 weeks of gestation and including the postpartum era, require special attention for some pregnancy-specific diagnoses such as eclampsia and cerebral venous thrombosis, so include your attending on the process early on. If they are normotensive and without neurologic signs or symptoms, they may not need neural imaging, but often will get labs to help risk stratify their risk of developing eclampsia or its variants. Altered mental status, fever, or nuchal rigidity is concerning for meningitis, which needs prompt antibiotics, as any delay in antibiotics can have worse outcomes, and so should be brought to your attending's attention right away. Focal neurologic findings are concerning for a stroke, classically hemorrhagic, but ischemic strokes can have headaches as well, and so it tends to follow a different pathway for a stroke workup that will not be discussed in this lecture. A thunderclap headache, described as sudden in onset and maximal in onset, is concerning for a subarachnoid hemorrhage. If a non-contrast head CT is obtained within 6 hours of onset, it can reliably exclude a subarachnoid hemorrhage. Therefore, if the patient has a headache that is concerning for subarachnoid hemorrhage within 6 hours from onset, discuss it with your attending, as a head CT may help eliminate the risk of further testing with LP or CTA. All females of childbearing age need an evaluation for pregnancy. This is an easy test to forget since the head is so far from the uterus and headaches are not typical symptoms of pregnancy. However, as with many complaints, pregnancy changes management. Often, pregnancy can change the differential diagnosis and diagnostic pathway, and almost always changes the medications that we give for treatment. ACEP Clinical Policies has indications for a non-contrast head CT, which helps evaluate for several emergent etiologies such as intraparenchymal hemorrhage or mass. Any of these categories would be an indication for a head CT, of which I summarize in the mnemonic CAT for CNS, atypical headache in AIDS or elderly age, or thunderclap headache. CNS refers to a headache with neural findings such as focal deficits, altered mental status, or change in cognition. Atypical, referring to a new type of headache, such as a feature different from prior headaches in anyone who is HIV positive or over the age of 50. Thunderclap refers to a new sudden onset severe headache. ACEP Clinical Policy Guidelines for a post-traumatic headache is a bit more complicated than necessary. When starting out, I would focus on getting familiar with the Canadian head CT rules, as it has excellent sensitivity and adequate specificity. Just remember to ask about being on blood thinners and check for altered mental status or focal neurologic findings, as they alone are indications for head imaging. Also remember to ask about loss of consciousness and amnesia, as ACEP Clinical Policies suggest using New Orleans rule if one of those are present. ACEP also suggests a head CT if a severe headache is present. This pathway is discussed in more detail in later slides. Acute angle glaucoma is an ophthalmologic emergency and a time-sensitive diagnosis, as delay in treatment can lead to permanent vision damage. So make sure to evaluate any eye pain, abnormal eye findings, or vision changes that could be concerning for this diagnosis. If you have any concerns, then get your department's IOP measuring device, which tends to be a pretty quick test and easy to perform, even in triage. discuss the difference in the thorough diagnostic algorithm. Cervical artery dissection, just like aortic dissection, can be very difficult to diagnose. Classically, it is from minor trauma and is associated with neck pain and can cause ipsilateral ischemic strokes. However, no history or exam finding is fully reliable at ruling out this diagnosis, and we want to catch this etiology before it progresses to a stroke. Some indicators for a CTA head and neck is minor trauma, history of connective tissue disorder, vascular findings on exam, or abnormal neurologic symptoms. Preeclampsia in pregnancy was also mentioned in the previous slide and will be discussed in more detail later. Cerebral venous thrombosis is another diagnosis to consider in pregnancy. However, realize that this diagnosis is not specific to pregnancy. It can be thought of as the PE of the brain, as other hypercoagulable states can also cause it, such as oral contraceptive use, old age, cancer, and pregnancy, which I remember as a mnemonic OCP. A blood clot to the venous system causes venous congestion, which raises ICP and causes papilledema, and classically causes nonspecific neurosymptoms such as altered mental status, seizures, or stroke symptoms not fitting in arterial distribution. Often can be bilateral. Headache with papilledema is also indicative of idiopathic intracranial hypertension, previously known as sonotubor cerebri. This highlights on two important diagnoses using papilledema, which is a very difficult exam finding. If you have trouble finding the optic disc on examination, you can use bedside ultrasound to measure the optic nerve sheath diameter, which correlates to ICP. After ruling out mass effect in the brain, direct measurement of ICP can be done with an LP, which also treats idiopathic intracranial hypertension. Other indications for an LP is meningitis or subarachnoid hemorrhage with a negative head CT, especially if after 6 hours from onset. Giant cell arteritis can be a very difficult diagnosis to make. Gold standard is to treat empirically with steroids while awaiting temporal artery biopsy, which is not a fully sensitive test. This is a diagnosis that does not occur in age less than 50 and classically occurs over the age of 60. Up to date has some vague recommendations for this age group when the headache is different than previous, any associated vision changes, jaw claudication, constitutional symptoms, or elevated inflammatory markers. However, none of these findings are very sensitive or specific. Finally, carbon monoxide poisoning is easily diagnosed with co-oximetry, typically from a venous blood gas, and is classically from some recent smoke or gas exposure and has similar sick contacts with headache and flu-like symptoms. Some suggested admit criteria are those diagnosed with an emergent headache diagnosis, or those without such diagnosis but have altered mental status or neurologic symptoms or signs. While this is not a comprehensive admit list, I mention it to highlight that some diagnoses may not be found in the emergency department and deserve further testing in the hospital. Every patient deserves good instructions on when to return and follow up. Some sample return instructions include fever, vision changes mental status, or any neurologic symptoms. The mnemonic I made for headaches is CAT scan and spinal taps, which is used for the differential and red flags. CAT are the indications for head CT. Spinal is for subarachnoid hemorrhage and meningitis, and it can also be used later to remember the indications for LP. TAPS is for trauma, cervical artery dissection, pregnancy complications such as preeclampsia and cerebral venous thrombosis, papilledema, which reminds you of the eye from anterior chamber like glaucoma, optic disc like idiopathic intracranial hypertension, and optic artery like giant cell arteritis. And S for smoke inhalation and similar sick contacts for carbon monoxide poisoning. Red flags for headaches can use the same mnemonic. Just realize that I created this list of red flags and it is not a documented list in literature, such as for back pain. The CAT is for indications for head CT. Indications for spinal tap is for syncope, pop of a thunderclap headache, Infection, to remember to ask about fever. Neck stiffness, defined as inability to flex the chin to the chest, and altered mental status. The T in TAPS is for trauma. The A is for cervical artery dissection, which you just asked about minor trauma, so you can use this A to remember to ask about connective tissue disorders. The first P is for pregnancy, which relates to eclampsia. However, pregnancy also increases your risk for blood clots, causing cerebrovenous thrombosis, as well as being on oral contraceptive pills, which is its own mnemonic for other risk factors of blood clots like old age and cancer. The second P is for papilledema, which is a reminder for the ocular-related diagnoses, so ask about vision changes and jaw claudication. The S is for smoke exposure or similar sick contacts, which relates to carbon monoxide poisoning. Note that this does not include typical descriptions of pain complaints, so still ask your character, onset, location, etc., as there are some key features that may lead to certain diagnoses, such as eye pain with reverse photophobia and glaucoma. This requires a familiarity with typical presentations of each diagnosis, which we will discuss in later slides. If there is a history of trauma, then you can use the mnemonic main hits to remember to ask about mechanism, amnesia, neurosymptoms, emesis, headache severity, intoxication, being on blood thinners, and seizures or loss of consciousness. Key features to the exam made include a detailed eye exam such as papilledema, proptosis, extraocular motions being intact or causing pain or diplopia, checking if they can identify number of fingers in all visual fields, palpation of the temporal artery pulse, visual acuity, and or checking of IOP. Head, ears, nose, and throat exam, as well as a good neck exam, including neck stiffness, is important. A detailed neurologic exam is very important. Additionally, good review of the patient's vitals are very vital. Now we can move into discussing some specific diagnoses. Unfortunately, most of these diagnoses are not well characterized, and so these slides tend to be a regurgitation of information from textbook, rather than my typical focus on high-yield information such as relevant likelihood ratios. However, I still try to stay focused on useful information commonly crossed in the ED. We can start with diagnoses typically evaluated for with a non-contrast head CT, such as intracranial hemorrhages. This slide reviews common risk factors or historical features for intracranial hemorrhage, the main of which is blood thinner use. Table 2 is a good table reviewing the efficacy and side effects of novel oral anticoagulants to warfarin. As you can see, when used in atrial fibrillation, each novel agent reduces the risk of stroke, while also reducing the annual risk of intracranial hemorrhages, which is why they are quickly replacing warfarin. However, I am cautious to blindly place patients on these agents given they do not have convenient reversal agents and these reductions are small. Therefore, I typically do shared decision-making with the patients, discussing the risk and benefits of warfarin and novel agents before starting them on blood thinners. The most common risk factor that is asked for in intracranial hemorrhage is the use of blood thinners or a history of trauma, though this table just highlights some other risk factors. Note that hypertension is on this list. However, blood pressure is not an indication for head CT according to ACEP clinical policies. Of course, if it is associated with altered mental status or neurologic findings or an atypical headache over the age of 50, then there would be an indication for a head CT. I mention this so that you do not feel like you have to scan every person with a headache and an elevated blood pressure. However, do trust your gestalt, and if you feel the patient needs a head CT, then order the CT, even if they don't meet ACEP clinical policies. Table 4 has some important historical features when it comes to intracranial hemorrhage. However, several of these are more relevant to the stroke workup, such as precise time of onset. The medication list is very important when a bleed is found as it relates to what reversal agent to give. Recognize that these numbered tables in my lecture are not mine. They are screenshots from EB Medicine articles. Table 6 talks about reversal agents such as vitamin K and PCC, aka K-Centra for warfarin. PCC is preferred over FFP because it does not have to be thawed and is a smaller volume load. But if you do not have PCC, then use FFP. The Bigatran or Pradaxa has a possible reversal agent that has been discussed in recent literature. You can also use dialysis or PCC. Reversal of the XA inhibitors can be attempted with PCC. There are some very recent advancements in potential reversal agents. However, these are not well characterized in literature yet. This table is a summary of a table from UpToDate discussing approaches to elevated INRs. If there is any serious bleed, regardless of INR, then PCC and vitamin K is used. If there is no bleeding and the INR is above 10, then hold warfarin and give oral vitamin K. Otherwise, INR between 4.5 and 10 will hold warfarin dose with possible use of oral vitamin K. I usually just look this table up when a patient has a supratherapeutic INR. Treatment of intracranial hemorrhage beyond reversal is trying to prevent the brain from further damage. This is done by reducing the intracranial pressure. The easiest of methods is to elevate the head of the bed, but you also should reduce the systolic blood pressure to below 140, which is usually done in conjunction with a neurosurgeon, though initiated by us as soon as possible. You can also protect the brain from further damage by avoiding hypo or hyperglycemia and hypo or hyperoxia. Mannitol or hypertonic saline can be used when there is clinical or radiographic signs of elevated ICP. Intubation is typically used to protect the patient's airway, especially if there is any decline in mental status. The typical cutoff is like GCS less than 8 in the setting of trauma. However, if you are transferring the patient and you have any concerns for decompensation, then it may be beneficial to do prophylactic intubation just to be aware that intubation can change the patient's hemodynamics and oxygenation, which can attribute to worse brain outcomes. However, airway comes before disability in the ABCs. Primary brain tumors are the most common brain tumors in pediatrics and are frequently a glioma, meningioma, or pituitary adenoma. In adults over 30 to 40 years of age, metastatic brain tumors are more common. Brain masses usually metastasize from another source, most commonly lung or breast, but also malignant melanomas or carcinomas of the kidney and GI tract. The classic triad for a brain mass is a severe nocturnal or early morning headache with nausea and vomiting. However, this rarely occurs. This classically occurs due to the increased intracranial pressure from laying flat, and this feature tends to be more common in pediatrics. The headache can classically be ipsilateral to the tumor, but can occur bilaterally. The majority of patients have other associated symptoms, but 2 to 16% can have isolated headaches. Associated symptoms can be nausea or vomiting in 40 to 60%, or neurosymptoms such as seizures, cognitive dysfunction, focal weakness, or fatigue that can present as new onset depression, especially in the elderly. While MRI is a diagnostic study of choice, head CT is a typical modality used in the ED. Hence why it always is important to have clear follow-up instructions as well as admit criteria such as altered mental status or neurologic findings. If they had a seizure, you can give an antiepileptic, but not typically done for prophylaxis whenever a mass is found. Steroids can be used if there are severe symptoms or threatening of herniation, but is typically done in conversation with a neurosurgeon. If there was loss of consciousness, it is typically because the mass was causing some increase in intracranial pressure. Steroids should be avoided if the mass is from lymphoma. The time frame for neurosurgical evaluation depends on the stability of the patient, severity of symptoms, and tumor size or location. However, this is usually decided by a conversation with a neurosurgeon. Brain abscesses are the main reason to scan patients with HIV and a new type of headache, as well as those with altered mental status or neurologic symptoms. They typically occur from some outside source such as hematomatous spread or direct spread from an ear infection, sinusitis, or dental infection. The classic triad is a headache with fever and focal neurologic deficits, but only occur 20% of the time. Patients can also get neck stiffness, vomiting, seizures, and increased intracranial pressure that can manifest as cranial nerve 3 or 6 deficits or papilledema. The The first neurologic finding of increased intracranial pressure is classically a lateral gaze deficit. Just like with masses, MRI is a diagnostic study of choice, but CT is typically used in the ED. While CT with IV contrast is better for identifying the infection, I do not typically see it used in the clinical setting, likely because it would require a second dose of radiation as the patient would need a non-contrast head CT and then the IV contrast study. And if a patient is altered or has neural findings, then they will end up getting admitted for an MRI. And if there is concern for infection, then they will end up getting prophylactic antibiotics at an LP. While it would make sense that a brain abscess missed by CT should be caught by a positive LP, this is not studied as patients with a brain mass typically do not get an LP due to the risk of herniation. Treatment will be managed with a neurosurgeon, and the antibiotic regime is determined by the etiology of the infection, which you can review here or look up when an abscess is found. Decadron may be used if there is substantial mass effect on imaging. Posterior reversible encephalopathy syndrome has characteristic neuroimaging findings of posterior cerebral white matter edema, often found in CT but best depicted by MRI, and typically have neurologic syndrome of headache with altered mental status, vision changes, or seizures. Classically, these patients are hypertensive, but some do not have severe hypertension, so it may be more related to the rate of change of blood pressure. Immunosuppressive therapy, renal disease, and lupus can also be risk factors. Treatment is focused on blood pressure control by either push-dose labetalol or nicardipine drip, which are typical medications used for neurologic hypertensive emergencies. Nitroprusside is an option if those are ineffective. Unlike intracranial hemorrhages, most other hypertensive syndromes require a slow decrease in blood pressure, not to exceed a 25% drop initially, in order to preserve perfusion to the brain. Such management and use of antiepileptics are typically done in conjunction with the neurosurgeon. Subdural and epidural hematomas typically occur from trauma, which we will discuss in the next slides. The difference is that subdural hematomas typically occur from weak bridging veins, such as in the elderly, alcoholics, or prior traumatic brain injury, whereas epidural hematomas are from a traumatic injury to the middle meningeal artery and are more classic in younger patients. 50% of patients with subdural hematomas are comatose. However, epidural hematomas classically have a lucid interval where they pass out initially and then have a normal mental status before deteriorating hours later. A very important feature to recognize is that subdural hematomas can occur with trivial head trauma or just deceleration injuries such as whiplash. The classic example that I have seen several missed head bleeds from are elderly patients that have a syncopal episode and so fall from a standing position and are not scanned because they, quote, did not hit their head, end quote. However, this change in momentum causes enough of shearing forces to cause tearing of the bridging veins. Hence why the Canadian head CT rule states to scan anyone over the age of 65. Here are the indications for head CT in the setting of trauma based on the ACEP clinical guidelines. Anyone with coagulopathy such as being on blood thinners or altered mental status or focal neurologic findings get a head CT, as these are exclusion criteria for the decision rules. Otherwise, if they have loss of consciousness or amnesia, then you use New Orleans rule. But if they do not have loss of consciousness or amnesia, then you scan if the Canadian head CT rule is positive or they have a severe headache. We talked earlier about the main hits mnemonic to help you remember the questions to ask. You can pull these up after your interview to check what the rule suggests. I would suggest getting used to the Canadian head CT rules first, as they are more common and they have a sensitivity of 100% with good specificity. I'm not sure why ACEP clinical policies suggest also to include a severe headache or the use of a New Orleans rule, of which has much lower specificity with similar sensitivity. However, the algorithm on this slide is what is suggested by ACEP clinical policies. PCON is a decision tool used for pediatric head trauma. This algorithm is a bit more difficult to memorize as there are slightly different features whether you are over or under 2 years of age. And the high-risk variables are indications for head CT, and the non-high-risk variables are indications for observation versus head CT. It is good to get used to which questions to ask, such as appropriate mental status, loss of consciousness, vomiting, and mechanism, as well as do a good head, ear, and neuro exam. Then you can always pull up the algorithm on NB Calc until you get familiar with it. If there are non-high-risk features present and the patient looks well, I usually do shared decision-making, explaining the risk of radiation versus missed significant injury to determine observation versus head CT. The frustration occurs once observation is chosen because it is not clearly established how long to observe them for, as each research article chooses different observation periods. The length can often be up to 6 hours, which almost always involves bed or nap times, which makes observing for mental status changes difficult. As well as parents usually do not want to sit in the ED for 6 hours. I usually explain this to the parents to make sure they know to watch the kid for 6 to 12 hours at home for any changes, and then do shared decision making for how long they are observed in the emergency department based on their symptoms and time of injury. It has been noted that patients on anticoagulation are at risk for missed head bleeds and so can develop a head bleed even though the initial scan was negative. It has been proposed to do a 24-hour observation in the hospital for these patients. However, this risk has been found to be low, and so hospital observation is not typically recommended. However, some special cases may indicate hospital observation, such as an INR over 3, or those who cannot be observed by a reliable adult at home or live far away from a hospital. While other blood thinners or bleeding disorders have increased risk for head bleeds as well, they are not as well characterized as warfarin, but generally fall under the same recommendations. As we discussed in chest pain, dissections can be a very difficult diagnosis to make. Classically, cervical artery dissections such as carotid or vertebral occur from minor trauma such as neck rotation, sports or Valsalva exercises, or head and neck manipulation. The most recent one that I diagnosed was during a wrestling match where the patient couldn't even describe to me any specific head or neck injury other than a typical grappling match. Furthermore, the injury typically occurs 2 to 3 days prior to the onset of symptoms. Therefore, 1/3 of the time they occur spontaneously or from forgotten trauma. This is why you should ask about history of connective tissue disorder. Classically, they have pain to the head, face, or neck, but this only occurs 80% of the time, and 8% of the time, pain is the only symptom. However, this is a diagnosis that you want to catch before it leads to a stroke. Additionally, this typically occurs in younger patients, average 46 years old, and hence a stroke in patients without stroke history should make you think of dissection. These features can be used for screening purposes, but nothing but imaging can really rule out dissection. There have been some criteria suggested for imaging that can be reviewed to help get a better understanding of indications for imaging, but nothing that is common practice. There are some skull or cervical fractures that are higher risk for cervical artery dissection, but this can be typically evaluated for by the trauma team or neurosurgeon. If you do find any signs of vascular injury on exam or abnormal neurologic findings, then a CTA head and neck should be performed. You can review these columns for such exam findings. As we discussed in the previous slides, head or neck pain are not always present. Diagnosis is usually done with CTA. MRI can also be used, but MRI is not typically used in the setting of trauma. Digital subtraction angiography, such as conventional angiogram, is considered the gold standard, but not typically the modality of choice, as CTA is more available. Treatment is with anticoagulation to prevent a stroke. 30% of patients develop strokes. Almost half of those are in the first day, but most occur in the first week. Mortality can range from 10 to 24%. Headache in pregnancy should make you think of eclampsia and cerebral venous thrombosis. Eclampsia tends to occur after 20 weeks gestation and has a range of stages and variants. If you want to view this diagnosis as stages, then stage 1 would be gestational hypertension, which is a diastolic blood pressure over 90 on 2 reads at least 4 hours apart, or 1 diastolic blood pressure over 110, or a systolic blood pressure over 140. This should be at gestational age over 20 weeks, as before 20 weeks it is usually undiagnosed essential hypertension. Stage 2 can be considered preeclampsia, which is gestational hypertension with proteinuria defined as over 300 milligrams in 24 hours, about 30 milligrams per milliliter on urinalysis, or 1 plus protein on urine dip. However, realize that urine dip is not very accurate, so in the ED, we are pretty much left with formal urinalysis, as 24-hour urine collection is not feasible. Stage 3 would be eclampsia, which is preeclampsia with seizures and or neurosymptoms, including headache, which is why a headache in pregnancy should be concerning to you. Furthermore, this is a diagnosis that you want to catch before it progresses to eclampsia. A variant of preeclampsia, and can possibly be thought of as a stage between preeclampsia and eclampsia, is HELP syndrome, which is hemolytic anemia, elevated LFTs, and low platelets, which is why CBC, CMP, uric acid, LDH, and UA can help risk stratify a patient with some concerns for preeclampsia. If you have any concerns or questions about this diagnosis in your patient, then a consult should be done with OB. Do remember that eclampsia can occur up to 4 weeks postpartum. Additionally, it can occur in less than 20 weeks gestation, but typically from a hydatidiform mole, hydropic degeneration of placenta, or choriocarcinoma. As just discussed, in HELP syndrome, these are labs that can be helpful in characterizing preeclampsia. The initial treatment of eclampsia is high doses of magnesium. Therefore, a baseline magnesium level is important. The dose is typically 4 to 6 grams IV bolus and then 2 grams per hour, and can be stopped when there is a loss of reflexes or respiratory suppression. Calcium can be used to reverse hypermagnesemia. Definitive management is delivery of the fetus. Discussion for management of eclampsia or preeclampsia should be done with an OB. If treatment of blood pressure is needed beyond magnesium, then labetalol or hydralazine is typically used with a systolic goal of 160 and diastolic 105. Cerebral venous thrombosis is classically thought of in pregnancy, but can occur in other hypercoagulable states, such as elderly over 65, cancer, or use of birth control. It can also occur from local or systemic infections or head injuries, including LP or jugular catheter. Headache is present 89% of the time and is classically occurred with valsalva or recumbency. This clot is in the venous system and so causes venous congestion, leading to brain swelling. There are 3 presenting syndromes, either intracranial hypertension, neurologic deficits, or encephalopathy. The neurologic deficits and encephalopathy are already indications for head CT, so if scanning for these reasons, just keep in mind the mentioned risk factors to think about ordering a CT venogram. However, without these syndromes, you are left with the intracranial hypertension syndrome, of which can be evaluated for with papilledema or optic sheath diameter. Just be aware of a specific venous thrombosis to the cavernous sinus, which have ocular findings predominate. This diagnosis is classically from an infection from the danger triangle, such as cellulitis to the upper lip, or sinusitis, or dental infections. It also may not be found with the typical CT venogram and may need a dedicated MRI for diagnosis. Since this version of a stroke occurs from venous congestion, the neurologic findings classically do not fit an arterial distribution and typically can be bilateral findings or diffuse, such as seizures. Classically, MRV is a gold standard test. However, it does not have a known. Now for the ocular diagnoses. Idiopathic intracranial hypertension used to be called pseudotumor cerebri because it would classically present as a brain tumor but without any tumors found. But was changed to IIH because telling people that they had a pseudotumor makes them feel like they have a tumor. This is classically in obese women of childbearing age and can be simply defined as a headache with papilledema without an identifiable cause. Another reason why the algorithm includes papilledema or optic sheath measurement by ultrasound. The headache is classically positional, such as laying down making it worse. Just like with brain masses where laying down increases intracranial pressure. The biggest associated symptom to be aware of is vision changes. While this diagnosis is not a life-threatening diagnosis, it is considered emergent because its risk to permanent vision loss. A specific finding for this diagnosis is pulsatile tinnitus, described as hearing rushing of water or wind, and can be constant or intermittent. Other syndromes can be back pain or eye pain. However, when this diagnosis is in question, make sure to do a good eye exam for deficit, papilledema, and visual acuity. An LP can be used for diagnosis after mass is ruled out and pressure less than 200 millimeters of water is normal, or with 250 is elevated, and in between is equivocal. Removal of CSF fluid is a short-term treatment option. However, long-term treatment can be done by removing the offending agent and or diuretics. Vitamin A, retinoids, or tetracyclines have been associated to this diagnosis. Low-sodium diet and weight loss has also been helpful. Acetazolamide is a first-line medication, but Lasix can also be used as an adjunct. If the patient is refractory to these interventions, then they may need surgery such as a VP shunt. Since we just talked about one indication for an LP, I am going to tangent for a few slides and talk about other indications for an LP, such as subarachnoid hemorrhage and meningitis. Ottawa has tried to make diagnostic criteria for subarachnoid hemorrhage, but has not been shown to be very useful. While the initial validation study showed good sensitivity, it had low specificity, and subsequent studies did not show good interobserval reliability, and it ended up increasing diagnostic testing. Therefore, I am showing it just to highlight some key points, but am not suggesting its use. First of all, inclusion criteria were those over age 15 with a normal mental status and a new onset severe headache with maximal intensity within 1 hour. Indications for testing included age over 40, neck stiffness, witness loss of consciousness, onset during exertion, and thunderclap headache. As you can see, neck stiffness has a very useful positive likelihood ratio of 6.6 if observed on exam and 4.1 if subjected. Focal neurologic deficits are a little useful at 3.2. Interestingly enough, loss of consciousness does not have a useful positive likelihood ratio. However, I would still suggest having a low suspicion to test for subarachnoid hemorrhage if the headache is associated with loss of consciousness. My assumption for the low likelihood ratio is that other etiologies can cause headaches and syncope, such as intraparenchymal hemorrhage or unwitnessed seizure or post-traumatic headaches. However, several of these are also indications for head CT, and if negative, then think about a CTA or LP if the history suggests a subarachnoid hemorrhage. Another interesting point in this table is the lack of utility of onset during exertion or intercourse. This is helpful because several Valsalva activities can cause headaches that are non-emergent, such as vomiting or exercise, and so this feature is not an indication for imaging in isolation. In my opinion, the biggest feature to remember about subarachnoid hemorrhage is a thunderclap headache, which by definition is a headache that is sudden in onset and maximal at onset. So it is always important to ask if it was sudden or gradual in onset, and then if it got worse, better, or stayed the same. This max intensity within the first hour is a definition I have seen in literature. Therefore, with patients that you have trouble eliciting thunderclap features reliably, I will often ask them at what time after onset it was maximal in intensity. Newer CT scanners, of which I believe are pretty standard in US CDs, have improved resolution now to the point that a non-contrast head CT within 6 hours of onset has phenomenal sensitivity and specificity, and so is suggested to stop diagnostic testing if negative, which is why it would be important to elicit your suspicion for subarachnoid hemorrhage during your MSE if the onset is within 6 hours, because if the CT is delayed, then the patient may need an LP or a CTA that could have otherwise been avoided. When an LP is done, the diagnostic criteria is over 100 RBCs and 2,4, or the xanthochromia, which is jaundice-appearing blood created by sitting in the subarachnoid space for some time. The RBC cutoff is difficult because traumatic taps are common, where capillary blood from the skin gets into your needle, making the CSF look bloody. However, traumatic taps should cause clearing of RBCs where there is much more blood in tube 1 and tube 4. However, there is controversy about the amount of clearing. A generally accepted but very conservative cutoff is 100 RBCs in tube 4. This slide does not talk about using CTA for diagnosis. However, when subarachnoid hemorrhage is found, a procedural angiogram is usually performed, and if an aneurysm is found, then it is coiled to prevent a rebleed that can cause death or disability. But if an aneurysm is not found, then no intervention is needed and the prognosis is good. Therefore, now that we have better access to convenient angiogram with CTA, we can use it to find the aneurysm, and if there is no aneurysm, then there is no subarachnoid hemorrhage to intervene on. However, the argument against this strategy is the false positive risk of finding aneurysms that are not causing their headaches and may never cause a problem, of which will then cause unnecessary interventions and prolonged fears to the patient. As mentioned, treatment is with neurosurgery to help with coiling, and so the patient should be NPO. The use of Keppra is controversial and should be done in conversation with the neurosurgeon. To prevent increased intracranial pressure, elevate the head of the bed and drop the blood pressure below 160 systolically with similar meds mentioned before. An important drug to remember in subarachnoid hemorrhage is nimodipine, which is a calcium channel blocker that helps prevent vasospasm because vasospasm can lead to permanent neurologic sequelae. Meningitis is an infection to the dura around the brain, and encephalitis is similar but involves the brain tissue. Therefore, the classic triad for meningitis is fever, nuchal rigidity, and altered mental status, which is only present 44% of the time. However, if they all are absent, then it is very unlikely to be meningitis. Neck stiffness and/or occipital pain is found in subarachnoid hemorrhage and meningitis due to irritation of the meninges. The main difference in encephalitis is the addition of abnormal brain function such as altered mental status, neurofindings, behavioral changes, or seizures. One study showed that fever was present on admit about 98% of the time. However, this included right atrial temperatures, which we do not perform, and only included admitted patients. Another article stated that fever was present on initial ED presentation, 95%, but other articles showed 74 to 85%, and that another 4% developed fever within 24 hours. I bring these up to mention that absence of fever should not be the sole reason not to work up meningitis, and also to remind you to give good return instructions for any fevers that may develop. Nuchal rigidity and altered mental status were present 88% and 78% of the time, and nuchal rigidity was defined as inability to touch the chin to their chest. Just remember to include all three of these features and not rely on one single characteristic. Encephalitis is typically viral, and the main etiology to remember is HSV because early treatment with acyclovir correlates to better outcomes. This is classically an infection to the temporal lobe and causes seizures and can be fatal if not treated. Acyclovir can also treat varicella, so look for a shingles rash, but this is not necessarily a time-sensitive diagnosis. Many other etiologies cause encephalitis but do not have treatments, so can be worked up by a neurologist during their altered mental status workup. Labs are non-diagnostic and should not be used to rule out meningitis. An LP is needed. However, an LP should not delay antibiotics, as the sooner antibiotics are given, the better the outcomes. CSF analysis is like your analysis, where we have to correlate several features. Diagnostic levels for meningitis are an opening pressure done in left lateral cubitus position of 200, protein over 220, CSF to serum glucose under 0.4, glucose under 4D, WC over 5, and positive grand stain. However, realize that none of these are perfect, as 9% of meningitis patients had a pressure under 140. Traumatic taps can have WBC and RBCs, and so a suggested calculation is to subtract 1 WBC for every 500 to 1500 RBCs. Different gram stain results can indicate different potential organisms. Encephalitis should classically be found on CT or MRI, but these modalities are more meant to rule out other diagnoses. An LP should be positive and typically consistent with aseptic meningitis and is rarely negative. A negative LP would imply pure encephalitis. CSF can be sent for PCR analysis for HSV or enteroviruses and other etiologies based on history, such as zoster PCR. Antibiotics treating meningitis need to be given as soon as you suspect a diagnosis and should never be delayed for the LP. If there is a suspicion for pneumococcal meningitis, then you may want to give Decadron before antibiotics to reduce complications caused by swelling due to dying organisms. However, it is not possible to know if it is pneumococcal without the LP cultures, and Decadron after antibiotics are not beneficial. So Decadron is not common practice. The typical regime for immunocompetent individuals is vancomycin with rosefin, and if under 1 month of age or over 50 years of age, then ampicillin is added for listeria. Immunocompromised individuals would get cefepime or meropenem instead of rosefin. Acyclovir treats HSV and zoster encephalitis and should be given empirically for all suspected cases of encephalitis. Glaucoma tends to be pretty easy to diagnose. There are different devices to measure IOP, but it tends to be a quick bedside exam. Normal IOP is 8 to 21, but acute episodes are often over 30 and typically over 40. If left untreated, it can quickly lead to permanent vision loss and so should be considered an ophthalmologic emergency and treated promptly. Therefore, if you have any concern for this, check the IOP during your MSc exam. Glaucoma pain is typically exacerbated by going into dark spaces because it dilates the pupil, decreasing the angle for the fluid drainage. The vision changes classically start from periphery and progress to central vision and can have halos around the lights. This pain is typically severe and associated with nausea or vomiting. The eye is usually injected with a cloudy cornea and an abnormal pupil that is mildly dilated and can have synechia, which is the iris stuck to the cornea, causing an irregularly shaped pupil. Treatment is usually quicker than an ophtho exam and so should be started promptly. I remember the mnemonic TAP, since you have to tap the eye to measure the IOP, where T is timolol, A is acetazolamide, and P is pilocarpine. Ipronidine can also be used. IOP should be rechecked, and if still dilated, then repeat drops and work on opto transfer. Keep rechecking the eyes for need for repeat drops. Resistance to medication may need ophtho intervention such as iridotomy, where they make a hole in the iris for fluid drainage between the chambers. Giant cell arteritis is a vasculitis that can cause a headache and can be very difficult to diagnose. It only occurs in those over 50, and incidences keep rising with age, so less common in their 50s and more common in their 60s and peaks in their 70s. 15% of these patients have polymyalgia rheumatica, which is an inflammatory muscle disorder that causes proximal muscle pain and morning stiffness. This headache is classically over the temples, but can be elsewhere. A key feature is any vision change, but classically is amaurosis fougeau, which is transient vision loss and typically unilateral. This only has a positive likelihood ratio of 3.4, but is the strongest predictor of permanent vision loss. A classic characteristic is jaw claudication, which 50% of these patients have, and has a positive likelihood ratio of 4.2, and is a feature that is best predictive of a positive biopsy. Since this is an inflammatory condition, they typically have constitutional or flu-like symptoms with a low-grade fever. Typically, our diagnostic test of choice in the ED is an ESR, which in a lot of conditions has a high sensitivity but low specificity. However, this is not so true in GCA, as it can commonly be negative, where 11% of patients have a level below 50 and 5% below 40. Palpation of the temporal artery is a typical exam finding, which I typically perform to document that I thought of the disorder, however does not have much clinical utility, as it usually is unremarkable in GCA. Though if you do notice a prominent or enlarged temporal artery, it can increase your suspicion for the disorder, but an absent pulse or temporal tenderness is not helpful. The typical study is a temporal artery biopsy, but can often be negative and only has a sensitivity of 87%. Luckily, we can treat this disorder with steroids while waiting the biopsy to be performed. However, it should be done within a couple weeks, and so you should consult a specialist to get it arranged, such as a general surgeon. Color Doppler ultrasound can have good sensitivity, but is very operator dependent and not performed at every center. However, it may be useful to ask your ultrasound tech when you have a concern for this diagnosis. Treatment is with high-dose steroids, typically a long prednisone taper. However, if there is any vision loss, then the patient should get IV salmeterol for 3 days before initiation of prednisone. This helps reduce vision loss, so should be started early, and symptoms tend to cause symptomatic improvement in about 2 days. However, keep side effects and complications of steroids in mind. I include the diagnostic workup from up to date to elicit the difficulty in this diagnosis. Initial criteria suggested here is to start with age over 50 and be concerned if there is a new type of headache, abrupt onset of vision loss, especially if transient and monocular, jaw claudication, unexplained constitutional symptoms, or high ESR or CRP. However, these features are very nonspecific, as the new headache does not even include any specific features to GCA. Jaw claudication is not uncommon and can occur with TMJ or teeth-related pain, and many patients with flu or cold have an associated headache. So use your discretion as to when to work this diagnosis up. The rest of the algorithm is a long stepwise process where if something is negative, then proceed to the next option as no test is fully sensitive. Carbon monoxide poisoning was also discussed in the dyspnea lecture, so I use the same slide for familiarity. The difference is that headache can be one of the early symptoms, with dyspnea usually developing after. Therefore, I have a lower threshold to work up carbon monoxide poisoning in solitary headaches rather than solitary dyspnea. I will typically start by asking about any recent smoke exposures or similar sick contexts, as a classic scenario is smoke exposure from car exhaust, house fires, or burning wood in the living room to keep warm in the summers, and they classically present with everyone in the environment being sick, even their dog. Stroke is mentioned in the differential. However, as we discussed, if you have neurologic findings concerning for a stroke, the pathway is typically much different than this headache approach. 87% of strokes are ischemic, and treatment can be with TPA if given within 4.5 hours of onset, and/or mechanical thrombectomy if a large vessel occlusion, but the time frame is vague and can be 6 hours or possibly up to 24 hours. Blood pressure needs to be below 185/110 before giving TPA. Symptomatic hemorrhage from TPA occurs about 3 to 6% of the time, and if given within 3 hours has a number needed to treat of 10, and if between 3 and 4.5 hours, a number needed to treat of 20, which would correlate to about 10 to 5% chance, respectively, which is slightly better than the rate of symptomatic hemorrhage transformation. Here is a review of the exclusion criteria for TPA, which is difficult to memorize, so usually a worksheet is filled out with the patient, but important to review before a test as it is common exam questions. Here are my references. Thank you for participating in this lecture.